Great. Okay. So I want to start out with, as was mentioned, I'm a pediatrician. And so my biases, my interests are always towards what's in the best interest of kids. And then my other passion is minority health disparities and racial equity. And so I'm always bringing those lenses to any health policy discussion. What's in it for kids? And how does this build or not build racial equity? So these are a couple of pie charts. On the left, you have the U.S. child population and then the U.S. total population, and then the uninsured child population and the uninsured U.S. population. Many of you may have heard about the United States becoming a majority people of color country in the 2040s. I would encourage you to revisit that time frame and understand that that's happening now. That our child population is already majority people of color. And when it comes to the uninsured, whether you're talking about children or the U.S. uninsured population, those have been majority people of color forever. Ever since we've had this broken, fragmented healthcare system, people of color have been really the ones struggling with it the most. And I put up these slides to really put the question up front about who is our healthcare system for? And I would argue that it's really for none of us, but it's definitely not for people of color who are rapidly becoming the majority of this country. And so we have to really ask ourselves, is this healthcare system ours in any sense of the word our? Okay, so when it comes to the legislation, there are two bills. The Senate bill, oh, I just realized I have a typo on this slide. This is legislation in the 118th Congress, not the 117th. Sorry about that. But the two Senate bills are the Senate side, Senate 1655, and the House side is HR 3421. The Bernie Sanders bill has had 14 co-sponsors since it was launched back in 2017. I feel like this number has stayed pretty strong as far as like 14 co-sponsors. The House bill has fluctuated. It's gone as high as I think 125, and now we're at 113. But even so, this still is over half of House Democrats. So whenever anybody is talking about Medicare for all as some kind of fringe leftist policy, I would really push back on that, saying that, well, if half of the House Democratic caucus is supporting this in one way or the other, either hyper vocally or even, just a little vocally, the fact that over half of House Democrats are willing to put their name on it as a co-sponsor is significant, and this keeps growing. I feel like the between the pandemic, economic downturns across election cycles, these numbers have held steady and keep growing. Okay. So the reason why I bring up both of the Senate and the House bills is because there are some important, there's a lot of overlap, but there are some differences. So one of the things to understand is that both bills cover all US residents, and so that is different than saying all US citizens. There are people who live in the United States who are, on their way to becoming citizens or are in different pathways of immigration, but pretty much Medicare for all is for anyone who can prove that they are a resident of the United States. Both bills would transition patients currently in Medicare, Medicaid, the Children's Health Insurance Program, the Federal Employee Health Benefit Program, and employer-sponsored insurance. All of those patients get transferred into Medicare for all. The VA and the Indian Health Service systems would continue to operate as independent agencies with a plan to look into rolling them into Medicare for all somewhere down the line, about I want to say like 5 years, maybe 8. On the House side, the timeline for this transition plan is pretty fast. So year one would be everybody under the age of 19, and everybody over the age of 55 is auto-enrolled into Medicare, improved Medicare, that is. In year two, everybody else. The Senate bill is a bit of a longer transition timeline. The first year lowers Medicare eligibility to 55. It auto enrolls kids under the age of 19. If you are a worker and want to buy in, you can. And in year two, that eligibility age goes from 55 to 45, and then to age 35, year four, it's everybody is automatically enrolled. These are all of the benefits that are covered under Medicare for All. Obviously, I'm a pediatrician, so I emphasize pediatrics, but you can see this is very comprehensive. And what's also important to note, and I think somewhere one of the other panelists will be covering how dental, vision, and hearing is already being talked about as an upgrade for Medicare, as are the long-term services and supports. I think Kamala Harris just recently dropped a policy proposal to make that happen under Medicare. So already these are benefits that are going to be debated for upgrading Medicare. Medicare for All looks to put this entire package into the benefits. Okay. So a big question that comes up among healthcare providers is like, well, how do doctors and hospitals get paid in all of this? So the answer to that is global budgets. And so it's important to understand how this works. And it's not as complicated. Well, it can be as complicated as you choose to make it, but overall, the federal government would be setting aside annual funding for hospitals and giving those funds in monthly installments, very similar to how the local governments fund fire departments. And you can imagine that if a fire department ever needed extra funds for unexpected problems, state and local governments support that. In this case, the federal government would be supporting healthcare systems when unexpected problems arise, whether that be epidemics, economic downturns, or or climate change disasters. Extra funds would be made available. Any surpluses go back to the feds. Right now, a lot of our health policies allow hospitals to pocket surpluses, and a lot of the times those surpluses are ending up in the pockets of private equity firms, insurance companies, and a lot of places that have nothing to do with healthcare or benefiting patients. So global budgets are a really smart way to create sustainable funding for hospitals and doctors, and it's predictable funding. And now, when it comes to capital projects, those are going to be funded through grants based on needs. And so, the example of capital projects, you have like a range of these. You have frivolous ones like the atria that you see at fancy hospitals. And then you have other capital projects like a third or fourth MRI suite for a hospital that may or may not need all of that. And in this case, what the Medicare for All system is saying is that you can apply for a grant, and depending on how you prove the need and benefit for this project for the community, will decide whether and how much to fund it. As you can imagine, this would get rid of a lot of wasteful spending. You're not going to be seeing a bunch of like fancy theaters, being slapped onto hospitals, and these almost like art gallery style edifices that get added onto hospitals. A lot of that is going to be funded not through taxpayer dollars, but probably through other private means. And so your taxpayer dollars are going to go towards constructing healthcare that is actually, what the community needs. Another way that we are going to be paying hospitals and doctors is really through a simpler billing process. Right now, you have entire floors of hospitals that are dedicated to going through billing, making sure that it's accurate, making sure that it's maximizing reimbursement. And when really kind of simplify the process, there isn't really a need to go chasing after patients with the best insurance. There isn't a need to stratify, like, okay, like we're gonna like really try to offer these patients with these health plans XYZ services, and everybody else is going to get like kind of a ground floor level of treatment. And you have an entire admin process that is dedicated to the stratification. And when and you're going to have a lot of that be simplified because there's just one biller. And there's projections of about $150 billion being saved by this, and that's I think, a fairly conservative estimate. Overall, this entire system of global budgets, having capital projects funded through grants and simplified billing, all of this put together really means that you've got much more sustainable funding for the hospitals that really need it, hospitals that are taking care of patients that don't have a lot of money, or children's hospitals. And as a pediatrician, I just want to say, like, this is vitally important. In the most recent winter, we went through a triple pandemic of COVID, flu, and RSV, and this was at the same time that hospitals were actually closing down their pediatric inpatient wards, and there were simply not enough beds for kids who needed them because pediatrics doesn't make a good business case under our current system for keeping those beds open. Under a Medicare for All system, it's a lot simpler. It actually says that, well, there's a public health case, not a business case, to keep pediatric beds open for pediatric patients. Okay. Impacts on, like, what does this mean for patients and prescriptions? So one of the best things about this is that all hospitals and doctors are in network. You don't have, like, a patient doesn't have to worry about, like, oh, is this specialist going to be outside of my network, and am I going to be getting a huge bill because they're contracted by the hospital but they're not part of my insurance plan? Nope, none of that. Everybody is in the same one network. Obviously, this makes services a lot more equitable. Right now, across like huge portions of the country, you've got these deserts where it is very difficult for pregnant women to get OBGYN care. As I was mentioning before about child health services, it's becoming tougher and tougher. And what that is a reflection of is our healthcare system builds these services closer to the people with money and closer to the systems that can sustain them financially. And they're not building a lot of that in places where they are actually needed. And so we end that with Medicare for All by centering public health instead of business. And our current system, it really does create a breeding ground for private equity firms, vulture capitalists, and a bunch of other folks who have no interest whatsoever in public health, but have a ton of interest in profiteering. And you create systems of wasteful spending and a lot less useful services. Many of you have probably heard about safety net hospitals shutting down after having spent tons of money on stupid things like on unnecessary imaging suites or other kinds of services that were not going to be used by the community that those hospitals were meant to serve. And then they go belly up because they've got a ton of debt. The private equity firms close them down, and they walk away without any accountability whatsoever to the impact on public health. Another way that patients benefit is by having no deductibles or copays. There might be some limited copays for brand name prescription, just so that way patients are using more generic meds instead of brand names. But these copays are not going to be anything onerous like they are today. Medicare has already started negotiating prices for drugs and devices, but there's going to be a lot more approaches that are going to be deployed that are going to aggressively bring down a lot more prices for a lot more medications. And a lot of people worry about, well, sorry, first off, this is going to be creating a ton of savings, $300 billion. And a lot of people worry about whether Big Pharma is going to leave. They're not going to leave. I mean, like, they've been happy to set up shop. Like, Sanofi is in France. They haven't left. GSK is in, like, all kinds of parts of Europe. They haven't left. So yeah, I mean, Big Pharma is not going to walk away from a country of 330 million people, because it would be a stupid business tactic if not anything else. So Big Pharma is not going to go anywhere. They're going to come to the negotiating table. Another big question that activists get is, how do we pay for it? There are higher taxes, but it's a question of who pays what, right? So we have like the ultra wealthy who have never paid their fair share. Now they're paying their fair share. And you and I, and as workers, are going to have payroll taxes, but What we're not going to have is we're not going to be seeing our employer take a chunk out of our paycheck and then the insurance company taking a chunk of it out of our paycheck every month, and then we not getting to use healthcare because we're still waiting for like a time like this, the end of the year, to kind of figure out like, okay, like am I, going to like meet my deductible and then is my insurance going to, kick in? No, we're going to have like, I mean, like a smaller amount taken out of our paychecks, but we're going to have the peace of mind of knowing that we can go to the doctor whenever we need to. The savings in the system are going to be huge. As I was mentioning before, I mean, hundreds of billions of dollars saved in administrative work, more hundreds of billions of dollars saved in negotiating drugs and devices. And overall, you're going to be getting more bang out of your buck for the money that is being spent in Medicare for All. So I would argue that, like, I mean, one of the things that gets overlooked with how we pay for it is that we're actually going to get a lot more value for every dollar spent as opposed to how we have money spent in our current system. And to me, the question of like how we pay for it is not nearly as important as like how do we actually redistribute savings so that we're actually creating equitable care, and also how are we taking those savings and moving them to things that we know actually impact health, like housing, education, transportation, things that actually impact health that have nothing to do with clinical medicine but have everything to do with the built environment that impacts people's health on a day-to-day basis. So obviously now is the time for single payer. I respect the ACA. I am a pediatrician, so obviously I respect Medicaid and CHIP. But let's be honest, these are important but insufficient systems. I'm speaking to you from Maryland. This audience is in Florida. We're in totally different worlds when it comes to Medicaid, and that's a real shame that like where you live makes such a big difference. And even if you have private insurance, like it's unreliable for just how unusable it is. The current fragmented system, it's just inefficient, it's unjust, it's unsustainable. And what we have is a system where you have to answer the following questions in order to get access to healthcare. How much money do you have? Where do you live? What is your immigration status for you or for everyone in your household? And what you end up with these questions are inevitable racial inequities. I mean, these questions, whether people will own up to whether that they intend racial inequities or not, that is the end result of asking people how much money do you have, what state do you live in, what's your immigration status. Like though like these questions are at the root of our inequities in our current healthcare system. And so as you all know, right now healthcare is a privilege and it's not a human right. So what will single payer do where I live? I mean, I know that, I mean, this audience is very familiar with arguments made about like, oh, like, when you look at European systems or certain Asian systems, you can see that, they have much better healthcare. But, for the patients that I take care of in Central Maryland and Southeast DC and where I did training in LA, they never had to look across an ocean to see white people with great healthcare. They just had to look down a highway and or across a river. And it was very clear that, oh, over there, those are people having great healthcare. And like, they don't have to, I mean, like catch a bus and a train and whatnot to go and deliver a baby. Like, they just, go right across the street and the hospital is like right there. And I think that, this is like, about building healthcare where we live and not like, having to wonder what would it be like from across an ocean. Um, with single payer hospitals and clinics, are not going to be reducing services just because they're located in poor neighborhoods or serving poor people. You're looking at much more reliable funding, and with that funding, you can get high quality staff, the resources that you need. There is going to be funding to maintain racial equity across hospitals and clinics in both of the Medicare for All bills. And no matter what you earn, where you live, or what you look like, you're going to get healthcare when you need it. So I wanted to make this last second to last slide for my friends in Florida. This is the uninsured population in Florida. It's, as you can see, largely majority people of color. It's a little over 2.3 million people are uninsured. The uninsured rate is 11.2, well above the national rate. Um, the Florida's 24th congressional district, which has overlap with the state representatives district. The uninsured rate is 20.1%. Statewide, 64% of the uninsured are people of color, and the Florida population is 46% people of color. So it is an inequitable system. And I mean, and that's borne out further by, the utilization of the healthcare system, right? So only 7% of white people in Florida say that they're not going to a doctor in the past 12 months because of cost, but that's almost double for Black patients, 18% for Latino patients, 11% for Asian adults. And in across the state, 8 rural hospitals have closed. So these are all, I mean, a lot of this is going to be addressed through a single payer system. I don't mean to think that like single payer is going to end racism in healthcare or anything like that, but I do think that if the system that you are working in does not center racial equity, then you are not going to be able to ever address any of these issues. And I just wanted to make a quick plug for my organization, PNHP, and our student friends in Students for a National Health Program. We're going to be having our national conference in Chicago, November 16th. Would love to have as many of you can come out there. Please scan this QR code and share it with your physician and medical student friends. Would love to have them join the movement and be part of all of us.